Good day. My name is Christine Marie George, and I'm a professor at Johns Hopkins. And it's my pleasure today to present on our 4 years of longitudinal surveillance investigating the clinical and environmental epidemiology of Vibrio cholerae in the Democratic Republic of the Congo. And this study is part of the PICHA7 research program and is a partnership between my research group at Johns Hopkins, Catholic University Bukavu, and the DRC Ministry of Health. The rationale behind our work is to build longitudinal evidence on the clinical and environmental epidemiology of Vibrio cholerae in a cholera endemic setting in sub-Saharan Africa, building on the numerous studies investigating cholera epidemiology in settings such as Bangladesh. In addition, we aim to build evidence on the risks of cholera infections for the household members of cholera patients in sub-Saharan Africa. Previous studies in Bangladesh have shown that the household members of cholera patients are at 100 times higher risk of developing a cholera infection compared to the general population during the 1 week period after the cholera patient presents at a health facility. However, there's been no studies in sub-Saharan Africa investigating household transmission of Vibrio cholerae. Our previous research in urban Dhaka, Bangladesh, found that 20% of household members of cholera patients developed a cholera infection during the 1 week period after the cholera patient was admitted to a health facility, with 40% of households having at least one cholera-infected household member beyond the index cholera patient. These findings indicate that the household members of cholera patients are at high risk of subsequent cholera infections, and evidence is needed on this in sub-Saharan Africa for the development of targeted interventions. The final objective of our research that I'll present today was to build evidence on the effectiveness of rapid diagnostic tests for cholera in our cholera endemic setting in DRC. And this work was just published this week in Tropical Medicine and International Health. The research that I'll present today is part of our Preventative Intervention for Cholera for 7 Days, or PICHA7 research program. And our objective is to build longitudinal surveillance on the clinical and environmental epidemiology of cholera, allowing us to identify transmission pathways for cholera infections, and developing and evaluating targeted wash interventions to reduce cholera among high-risk populations residing in cholera hotspots. Our study site is located in eastern DRC, and we have ongoing research in both North and South Kivu. As part of the PICHA7 research program, in 2018, we established a PICHA7 enteric disease microbiology laboratory in Bukavu City in South Kivu province of DRC. In this laboratory, we analyzed both water and stool samples for Vibrio cholerae by bacterial culture. We also have the PICHA7 cholera surveillance system, which is conducted in partnership with the DRC Ministry of Health, where we conduct cholera surveillance at 119 health facilities in South Kivu. Now we'll go into our results of our 4 years of longitudinal surveillance of cholera as part of our PICHA7 cholera surveillance system, which was conducted from March 2020 to March of 2024. And as part of this surveillance system, 1,148 diarrhea patients admitted to our 119 surveillance health facilities were screened for cholera by bacterial culture. And 30% of these diarrhea patients were found to be bacterial culture confirmed cholera patients. The y-axis here shows the number of bacterial culture confirmed cholera patients. Now we'll look at the cholera over time in our cholera endemic setting. We observed outbreaks of cholera in spring and fall of 2020, followed by the year-long period when the COVID pandemic intensified at our study site and there were many lockdowns. We continued our cholera surveillance, however, did not identify any cholera patients during this period. This was followed by when a large-scale cholera vaccine campaign was delivered at our site in December of 2021, which included 896,000 individuals receiving 2 doses of Uvacol Plus. After this point, there were very few cholera cases over the next year and a half, with a large cholera outbreak occurring in the spring of 2023, followed by a smaller one in the fall. As part of our cholera surveillance activities, we investigated household cholera transmission in our cholera endemic setting in the Democratic Republic of the Congo by conducting a prospective cohort study of cholera patient households. We enrolled cholera patients and their household contacts, which were defined as individuals residing in the same home and sharing the same cooking pot with the cholera patient for the past 3 days. Cholera patient households were followed during the 1-week high-risk period for cholera infections through making household visits at day 1, 3, 5, 7, and 9 after the index cholera patient was admitted at a health facility for treatment. During these 5 household visits, we collected stool samples from all household members, as well as stored drinking water and water from the household's drinking water source to test for cholera by bacterial culture. Now I will go into our results of our prospective cohort study of household cholera transmission in DRC. We observed, similar to Bangladesh, that 19% of household contacts of cholera patients had a cholera infection during the 1-week period after the cholera patient presented at a health facility for treatment, with 56% of cholera patients' households having at least one cholera-infected household member beyond the index cholera patient during this period. These findings indicate a very high risk of cholera among the household members of cholera patients and the need for targeted interventions for this high-risk population. Next, I present here the findings from the water samples collected from cholera patient households during the 7-day high-risk period after the cholera patient was admitted to a health facility. On the right, we show an example of the type of water sources that are used in our setting. We found that 10% of cholera patient households had a stored water sample with Vibrio cholerae detected by bacterial culture, and 5% of households had a source water sample with Vibrio cholerae detected by bacterial culture. Since stored drinking water had twice the amount of cholera present compared to the source water samples collected, this suggests contamination of stored drinking water in the home. Now I will present the findings from our evaluation of the Crystal VC rapid diagnostic test for cholera at our study site in DRC. This evaluation included 644 diarrhea patients from 94 health facilities in South Kivu. We compared the Crystal VC01 RDT to a positive result by bacterial culture or PCR for Vibrio cholerae. We observed a specificity of 94% and a sensitivity of 90%. And this aligns with the Global Task Force for Cholera Control recommendation for cholera RDTs of having a sensitivity of at least 90% and a specificity of at least 85%. The positive predictive value for this RDT was 83%, and the negative predictive value was 97%. These findings show a high performance of this RDT in this cholera endemic setting to detect cholera. Now I would like to provide a summary of our study findings. First, we observed endemic cholera at our study site in eastern DRC during our 4 years of longitudinal surveillance, with a quarter of diarrhea patients presenting with cholera confirmed by bacterial culture. Next, we observed a high incidence of cholera among the household members of cholera patients, with 56% of cholera patient households having at least one cholera-infected household member other than the index cholera patient. This is the first prospective cohort study on the household transmission of cholera in sub-Saharan Africa. Next, we observed a high sensitivity and specificity of the Crystal VC01 RDT for cholera in comparison to bacterial culture and PCR. So in conclusion, these findings demonstrate the urgent need for targeted water sanitation and hygiene interventions for the household members of cholera patients to reduce cholera among this high-risk population. In an attempt to reduce cholera among the household members of cholera patients, we developed the preventative intervention for cholera for 7 days, or PICHA7 WASH program, which we developed through 18 months of community-centered formative research. In our recent randomized control trial, the PICHA7 WASH program, among 2,300 participants in Bukavu, DRC, we found that this program significantly reduced health facility visits for diarrhea and diarrhea with rice water stool among the household members of diarrhea patients. This promising result suggests that the PICHA7 program may present an option for cholera control in our cholera endemic setting in DRC. I would like to conclude my presentation today by thanking the study participants that participated in our research activities, acknowledging Welcome that funded our work, and acknowledging the contributions of my colleagues at Catholic University Bukavu, the DRC Ministry of Health, and Johns Hopkins for their dedication to the implementation of this research. Thank you.